Yeah, Assalamualaikum warahmatullahi wabarakatuh, and very good morning to everyone. So today we'll be having a radio conference for two cases. The first one is Azli bin Ghazali with a diagnosis of aggressive soft tissue sarcoma, left hand and wrist, with differential diagnosis of malignant peripheral nerve sheath tumor. So the team involved would be ORU team and team. And for today radio conference with the radiology department, and we also invited pathology department. So a little bit history of this patient. He's a 50-year-old gentleman with history of left hand swelling for past approximately 10 years ago, with progressively increasing in size. So patient had a follow-up to our center and was done MRI in 2012 with the features of suggestive of peripheral nerve sheath tumor, which most likely neurofibroma. However, subsequently, patient defaulted follow-up. And patient came again with a complaint of rapid growing in size for past 3 weeks, which grow constant to patient, associated with pain and numbness, which not resolved with any analgesics. There's also restricted range of motion of the left ring and left little fingers. Otherwise, there's no constitutional symptoms, no shortness of breath or chronic cough, and there's no other swelling as well. On physical examination of the left hand and wrist, there's a large multilobulated mass of the palmar ulnar aspect of left hand, extending to dorsal ulnar and volar ulnar distal left wrist, with a thinning of the skin and dilated cutaneous vessels. However, there's no erythema or no ulceration. It is a mixed cystic and solid inconsistency. It is non-mobile, thinner sign positive, no bruit or trill, left little and ring finger in flat position but partially corrected. There's also reduced cessation of ulnar nerve distribution. The vascularity of all fingers are still intact, and there's no axillary lymph node was palpable. Here's the clinical features of the patient's left hand and wrist. So patient has done MRI on 24th June and was proceed with ultrasound guided through cut biopsy on 25th June. Patient was planned for staging CT thorax and given date was given on 20th July. So the purpose of the radio conference is for disease progression of the peripheral nerve sheath tumor, to know the nature of the tumor, the systemic burden of the disease, and for surgical planning. I think this is for the first case. I'm going to pass to our radiological team.
Good morning. I am Namrata from the radiology team. So I'll begin sharing my slides. Sorry, my images. So, one, go. So everybody can see my screen? Start with the radiograph done on the 2nd of June. So from this radiograph, we can see there's a large lobulated soft tissue mass on the ulnar and on the palmar aspect of the left hand. Then the ring and the little finger are held in flexion. But on the mass itself, we see a few foci of calcification here, but we don't see, and here also, but we don't see any obvious air or fluid within the mass on this radiograph. And the salient features are there is pressure remodeling of the underlying metacarpals. We can see the sclerosis of the second, third, and fourth and the fifth metacarpal. The fifth metacarpal actually even has cortical breach with aggressive periosteal reaction, as we can see here and here. But the rest of the bone, the wrist bone themselves appear intact, and the distal end of the radius and ulna also intact. And the first metacarpal and the thumb appears spared from in this radiograph. So moving on, I'd like to show our initial MRI from 2012. So this is our initial MRI done in 2012. So begin here. This one in our T1 image. As you can see, this one is the mass. It's originating from between the flexor carpi ulnaris and the flexor digitorum profundus. So initially, the mass is superficial to the flexor retinaculum here. So we can see the median nerve in the carpal tunnel is still preserved, but as the mass as we go towards the palm, the mass insinuates between the flexor compartment and the metacarpals, as you can see, and there is displacement of the flexor tendons, and we can see the cortical erosion of the metacarpals already seen in 2012. So the mass initially is iso-intense on T1, heterogeneously hyper-intense on T2, and in our post-contrast study, we can see heterogeneous enhancement with areas of non-enhancement in the center, probably due to necrotic center. I would like to highlight on this one our coronal view. Actually, we have a smaller mass here over the radial aspect. So I'll move on to our current MRI. So this is our current MRI. So the mass previously seen here is much larger in dimension. Here again, originating from between the flexor carpi ulnaris and the flexor digitorum profundus. So it insinuates between the the pisiform bone and the flexor tendons. It's much larger in dimension. There is a thinning of the hypothenar muscles, and the flexor tendons are displaced. Also, there is erosion of the metacarpals. So the mass is iso-intense to the muscle on T1, heterogeneously hyperintense on T2, and shows heterogeneous enhancement with some areas of non-enhancement in the contrasted study. And this one in our coronal plane, I'd like to highlight the previously seen smaller lesion also is much larger in size. I'd like to show one more image. So this one is uh, this one is our DWI ADC study. As we can see on the DWI map and ADC, we have areas of restricted diffusion, yes, especially here. And this one is our GRE sequence. We can see there are blooming artifacts in the mass. So correlating with our ultrasound finding, this one is our ultrasound. Our ultrasound showed a predominantly solid mass with some areas of cystic cyst and with three foci of calcification. So correlating our ultrasound with the MRI, these areas of blooming artifact are likely due to calcification and or hemosiderin deposit. So based on our imaging, our first differential would be malignant transformation of peripheral nerve sheath tumor. Our second differential is synovial sarcoma. Any questions?
Do you have the radiograph taken on taken in 2012 so that we can compare with the current?
No, doctor. Unfortunately, we don't have any imaging except from the MRI from the initial presentation.
Any reason why not? So there's no radiograph taken anywhere and not available in HP USM. Any answer?
Sorry, Prof. Because this one we were not sure in 2012 regarding any, apart from the MRI, any imaging was done elsewhere. If it's from USM, there's only MRI. I'm not sure whether patient has actually taken radiographs at other hospital or clinic.
What was the oldest available hand radiograph?
It's only during the current admission.
2012 MRI only.
Otto, any response towards that?
Prof, I'm not sure about this one. I think maybe there was a radiograph taken at that year, 2012, but I'm not sure whether based on the version of the PAC system, whether the old radiograph was taken into archive. I'm not sure about that one. Because when the old note also, we don't have the old note for this patient.
Okay, thank you.
Sorry, actually,
Yes.
from our side, we would want to ask, during the initial presentation in 2012, how long history was the presentation in the sense the hand swelling? Is there any documentation on that?
So far, I didn't get that the history why, but based on the patient history, it was when patient have at the age of young age, probably the adolescent or young adult. But bear in mind, this patient has some intellectual disability as well. And then he is being taken care by the siblings. So in terms of history taking, I'm not sure whether it is accurate or not. But claimed by the patient, it has been there for quite some time since a young age, probably young adult.
Okay, thank you.
Dr. Shurabil, Dr. Emilia here. Is there
Yeah,
any
Prof.
previous biopsy done before for the swelling?
No biopsy was done. After the MRI, this is based on the history. Patient defaulted follow up since then.
From the image radiology just now, can I ask the radiology team, is there any capsule seen from the mass?
Morning, doctor. In terms of capsule, actually there is a well demarcated margin. The areas that we have mentioned as erosions are actually more of pressure erosions. But in terms of capsule, yes, it's actually a rather encapsulated mass.
So from the radiology point of view, is there any possibility that it is a benign peripheral nerve sheath tumor?
Not during the current imaging features. Using the current imaging features with the heterogeneity seen in the T2 weighted sequence and the heterogeneous pattern of contrast enhancement, it will point towards malignant transformation. Probably benign to begin with, but at this point of time, less likely.
Thank you.
So may I ask, radiology, you were talking about initially radiograph, there's a changes of the bone,
Yep.
second, third, fourth, and fifth, and then the thumb is bad. So what about the MRI? Any narrow changes within the bone, or any what we call it, infiltration into the bone?
Actually, in terms of marrow changes, the signal is still preserved, doctor. Because this is I'm using the T1 weighted. So these are actually, okay, going from the left to the right of the image. So this is actually the fifth metacarpal, fourth, third, and second. So in terms of marrow signal, it's actually still preserved. It's just that some part of the cortex is no longer seen due to the pressure erosions. And this is actually the first. There's a bit of motion, but this is actually a motion. That's why we're seeing as double image. But there's no abnormal signal seen within the marrow per se. And these are the carpal bones.
So, well, you will mention that this case, I mean, the mass is arising from the muscle. So and then you mentioned about this is case of suspected malignant transformation into MPNST. Then is there any specific nerve in origin for this mass?
Mm-mm.
Actually, we are suspecting ulna because this is the pisiform bone and then the flexor tendon. So this is the Guyon canal where we are supposed to see the ulnar nerve, artery, and vessel. So even during the prior MRI, that same region was obliterated, meaning we were not able to see the ulnar nerve, artery, and vessel. This one, doctor. Pisiform and flexor tendon. So likely arising from here if it's going to be a peripheral nerve sheath tumor. The radial nerve actually able to delineate even in the previous imaging. Give me a moment. The ones at the periphery. I show in our one. Okay, going from the forearm. Okay, if we follow this low density, it's a bit difficult to appreciate because it's a bit thick slice, but the radial nerve actually is visualized. And in terms of the median nerve, even the median nerve also we are able to see. This is actually the median nerve. So we are tracing it along the flexor, and it's actually seen within the flexor compartment. No abnormal signal. So the nerve that is actually not clearly visualized is the ulnar, even in the previous imaging.
Okay. So this mass is arising from the ulnar aspect of the hand. Then will you be able to describe or delineate the radial margin of this mass, whether it is involved, how extensive it has involved into radial part of the hand, and then whether the margin between this mass and the thumb or the first or index fingers.
Actually, from this coronal view, I think we're able to see the depth, as in how, sorry, not depth, the dimension across the fingers. So this one is the last, fifth, fourth, fifth, fourth, third, and second. And this is the thumb. So the involvement of the thumb relatively spared. It's just that it's already caused him to have like some sort of flex deformity of the interphalangeal joint. But as for the metacarpal phalangeal and metacarpal of the first, relatively spared. Second is probably up to the region of the metacarpal here, because this is the metacarpal bone second, and this is the webs. This is the widest dimension. If you were to see on the axial plane, okay, we just focus on the second. So this is the second. This is the metacarpal. So there's actually involvement between the second and the first web space, but the first is relatively spared. And the second metacarpal also, there's actually no obvious erosion or pressure erosion seen.
The heterogeneity changes that you mentioned, that is the sign of malignant transformation. Can you explain again what are the heterogeneity changes that is seen? That is the sign of malignant transformation in this image.
We tend to use the T2 weighted imaging. So in this, there are some areas like this actually denotes a cystic component, which is seen in ultrasound as well. And there are some areas which are dark. This actually, when we relate with GRE sequence, was the blooming artifact, and also calcification or hemosiderin. And like it's not appearing as homogeneously hyper or homogeneously iso. So this sort of appearance means that there is a few components which are involved in the tumor. And like one of our differential we have mentioned as a synovial sarcoma. So the patient actually has this triple sign whereby there is presence of high signal and predominantly the soft tissue signal intensities, and there are some which are dark. So meaning these are contributing to the triple sign, which is indicative of a synovial sarcoma. So these features are all which are pointing towards more of a malignant transformation rather than benign features.
Is there any possibility that the changes actually due to the cystic degeneration of the tumor?
Can, doctor, but that's probably only this part, the cystic component, which is actually showing no enhancement post contrast.
Okay,
But
thank
the
you.
rest,
Assalamualaikum and very good morning.
Sorry, have you
I'm
done for the first case?
Kalau lagi tak nak tengok ke?
We haven't done for the first case. So, sorry, Prof. Prof. Emilia, is there any input from pathology?
Dr. Siti Shatira, can you share the slides?
Can you see my slides?
No. Okay, boleh.
Assalamualaikum and good morning everyone. Thank you. So I just continue with our histological finding. So we received a specimen which was labeled as left-hand soft tissue, which consists of 6 strips of grayish tissue measuring 9 to 14 mm in length, and we submit entirely into blocks. So 3 strips in each block. So on microscopy, on low power examination, we can see there are strips of lesional tissue which shows the alternating hyper and also hypercellular area. If you can see, the darker, the denser one is the compact area, the hyper, and the loose or hypercellular area. And in one area, focal, we can see area of nuclear palisading. So if we zoom at this part, we can see the the spindle cells, they are arranged in a parallel row, which they are separated by the fibrillary process in between. So they are arranged parallel to each other. Macam ni. So in other area, the spindle cells are arranged in the fascicles, short fascicles with ill-defined fascicles. And if we go on the higher power magnification, we can see the lesion is composed of a blunt spindle cells, which has a tapered end, and it shows no prominent nucleoli. The cytoplasm is eosinophilic, and we can't really see the cytoplasmic border. So this is other area of the compact or the hypercellular area with ill-defined fascicle without nuclear palisading. So throughout the lesion, there are numerous areas which shows the hyalinized vessels. You can see the irregularly, some are ectatic vessels, which shows hyaline thickened vessel wall. This is the one. You can see the pinkish area within the wall of the vessels. And in some here, and then some here. This is the hypocellular area, which they appears as myxoid. And also some also contains the spinal cell as in the compact area. Also here we can see the presence of the hyalinized blood vessels, ectatic hyalinized blood vessels. There are no area of mitosis and also no mark or nuclear atypia seen throughout the lesion. So based on this morphology, we proceed with the S100 staining, which shows a diffuse cytoplasm and also nuclei staining in all throughout the lesion. We also proceed with the CD34, which only highlight the blood vessel and which do not show the lattice-like staining as seen in the neurofibroma. So our differential diagnosis at this time is based on the characteristic morphology of the alternating hypo and hypercellular area, or we call as the Anthony A and Anthony B area, and then the spindle cells which are blunt, which are elongated with tapered end, and also presence of characteristic nuclear palisading, resembling all called as the Verroque bodies, and then with numerous hyalinized thick wall vessel common, which strongly support towards schwannoma. And why this lesion is unlikely MPNST? Because the hypo and also hypercellular area is not as dense as what we would expect to be seen in the MPNST. And then there is no nuclear atypia or mitosis is hardly seen in this lesion. And necrosis are also not seen. So the S100 immunostaining shows strong diffuse positive, which points strongly towards schwannoma, and CD34 is negative or focal positivity. Whereas in neurofibroma, the S100 staining would be patchy or focal, and CD34 will stain positive. Whereas in MPNST, we'll have negative for S100 and also CD34. So this is the diagnostic criteria for schwannoma, which is the essential one which would need the histopathology of schwannoma, such as the Anthony A or Anthony B area, and also the extensive S100 staining. And then there are few desirable criteria such as Verroque body, subcapsular lymphocyte. This one we did not see because we only get the core needle biopsy. And then the hyalinized blood vessel, which is easily seen in this tumor. And also there is lack of the lattice-like pattern of CD34 staining. So based on all of these morphology, based on all of these features, which is strongly supports towards schwannoma. Neurofibroma is unlikely because based on the morphology that I've mentioned before. And also MPNST because there is no area of necrosis or marked atypia that we can see.
Is that all?
Yeah, Prof.
Okay, thank you. So, is that possible? If you want to go back to the radiology just now, schwannoma with cystic degeneration, is that possible? Because what we see only the strips of biopsy tissue. Whatever we saw, because I have seen this case yesterday, was referred to me yesterday afternoon. So I have because the immunostain also limited, but based on the immunostain that was done, the S100 positivity is actually against MPNST. And we know that the schwannoma can has the cystic degenerative changes. So maybe get back to clinical and radiology. Is this possible?
Sorry, Prof. Emilia, just want to ask, dalam slide tadi, the last column talking about H3K27 ME3.
Yeah.
So did you proceed with that one? Or is it not necessarily based on the other features?
Because this case was seen by different people before. So yesterday evening only I saw the case. So we have not done any other stain yet. But from the morphology point of view, with the S100 intense positivity, it is very less likely to be MPNST, because MPNST normally it will show negative S100 or maybe in a small percentage showing the focal positivity or patchy positivity of S100. But since if it is not tally clinically and radiologically, we can do more stain. That probably the one that we saw is just part of the whole picture of the tumor. Maybe it is part of the de-differentiated or something. We don't know. So if you think it is very less likely to be schwannoma, correlating with the radiology and clinically, and maybe we can do more workup on the tissue lah. Kita buat a panel of immunohistochemistry for this case. But I just asking you because the morphology is, when I saw this case yesterday, I can't think of any other things, because this is a very typical verrucate body scene. The picture actually is very characteristic of schwannoma. We don't find any evidence of mitosis, and it is known to have a cystic degenerative changes in schwannoma. That's why I'm asking whether is it possible looking at the radiology and clinically. But of course, if you want us to do more workup, we can do the immunohistochemical stain to rule out any other possibility of spindle cell lesion in this case. Yeah.
Yeah, Prof. What about the tissue quality?
Good. Adequate. Yeah.
Okay. So because if you talk about schwannoma, there's a subset of schwannoma that has this kind of feature, which is ancient schwannoma.
Ancient schwannoma.
Yeah.
Sebab dia dah lama tu, kan? Dia dah lama tu.
Yes. But we need to go back to the clinical and radiological, I suppose. And then because we are talking about hand tumor, So the aim of treatment is if we can preserve hand function as much as possible, then that would be the case. But if it is turned out to be a benign, then we may go marginal and then preserve probably in this case index finger and thumb, because if it is nerve involvement, I'm not sure how bad is. If it is schwannoma, it should be we can preserve the nerve. But looking at the MRI, it seems that the nerve is obliterated. So, and then patient having nerve ulnar nerve palsy. So that is the thing. If you think because all the points are towards schwannoma, and the histopathology also going towards schwannoma. And then is there any a further staining that could change the benign into malignant? I'm not sure about that one. Probably it's less likely. But in that case, if it is, we do the complete staging to see what about the lung. Is there any features of metastasis? And then we may really discuss this case. And then if it is towards benign, or we call it as ancient schwannoma, and then we can go for marginal and then send the whole bulk of the tumor. And if it is turned out to be malignant later on, then we can discuss on the next surgery, whether to go for proper margin, and then most likely is amputation for the second surgery.
If it is a schwannoma, it is very rare to have a malignant transformation to MPNST. Neurofibroma, yes, but it is not impossible. But it's very rare, malignant transformation to MPNST. Yeah, unless it is epithelioid type. Kalau dia transform, it will be transformed to epithelioid type of MPNST. In that case, S100 will be diffusely positive.
So if you talk about epithelial MPNST, then would you go for I1 staining?
Yes.
Okay.
Tapi untuk biopsi yang ini, kita tak nampak features of epithelioid tu lah. Tapi if we are talking about the malignant transformation from schwannoma, malignant transformation from the schwannoma, it will lead to epithelioid type of MPNST, not the conventional MPNST.
So Prof, based on this biopsy, it all looks typical features of a schwannoma, and then there's no epithelioid punya features. Would you still consider doing the INI one?
Kita buat lah, sebabnya the MRI features doesn't tally kan, the clinical pun looks aggressive, so I think I will do full workup lah for this case.
Alright, thank you, bro.
Okay.
So any more questions for this case? If no more question, then shall we proceed to the second case?
Okay, thank you.
Assalamualaikum and very good morning. I'm Shazwan from Oru team. So today, the second case is about Cik Dres bin Cik Muda. Diagnosis left intramuscular cuff mass for investigation. Differential diagnosis is soft tissue metastasis from suspected primary lung malignancy, blood malignancy, or primary soft tissue sarcoma. So the history wise is a 60 years old Malay male lipidemia, hypertension, and also hyperlipidemia. He was referred to ortho for left leg intramuscular mass throughout pregnancy. Initially, he presented with loss of weight, about 30 kilo in 3 months' time, associated with lethargy and dry cough for the past 3 months, and on and off. He underwent a PTB workup, but the result came back negative. He was admitted in the ward. Was done ultrasound left lower limb to rub DVT, but there is no DVT. But incidental finding of left intramuscular mass may represent soft tissue malignancy. Further history, he does not notice any swollen. He was told by his peer that his left leg was bigger than his right side. He denied any severe neck pain or fever. For the physical examination, for the left lower limb, there is a first swelling over posterior cuff on deep palpation, not warm, not tender, and no skin changes. Mass mobile, the mass is mobile side to side and vertically, less mobile on plantar flexion, whereas the RM knee and ankle was full, no foot drop, and the CRT was also is less than 2 seconds. X-ray, no OM changes or no fracture seen. This is the clinical picture for this patient. So the investigation was done. MRI left lower limb was done on 30 June this year, and also ultrasound guided biopsy of the left cast done also on the same day. So the purpose of this radio conference is for the radiological diagnosis, the systemic burden of the disease, and to evaluate the margin of resectability. I'll pass to the radiological team.
Assalamualaikum and a very good morning. I'm Yahya from radiology. So now I'm going to present the radiological findings for this patient. So first of all, I'll go to the Okay, first of all, I will go to the first imaging that was done during the presentation, where patient referred to ortho because of left leg swelling. So we did ultrasound left lower limb initially because to rule out DVT. So basically, there is incidental findings of the intramuscular mass at the left calf, likely arising from the soleus muscle. The mass is heterogeneous hypoechoic with presence of intralesional vascularity. However, there is no calcification within the mass, and then there is anechoic structure seen within the mass, likely in keeping with cystic component seen at the inferior aspect of the lesion. This one. And then the surrounding subcutaneous overlying subcutaneous tissue are slightly thickened. Then this patient proceed with MRI subsequently on 24th of June. So these are the MRI of the left calf performed on 24th of June. So this is T1, T2, stir and post contrast. So at the region of interest at the left proximal tibia fibula, our left side, we can see there is well-defined lobulated intramuscular mass seen at epicenter at the posterior compartment of the left calf, mainly involve the soleus muscle. And then the signal intensity of the mass, we can see at the T1, it is iso to hyperintense signal. And then on T2 vector, it is heterogeneously hyperintense, and then not suppressed on stir. And then on post-contrasted study, it is homogeneously enhancing. And then I would like to show the signal intensity in GRE as well as DWI ADC. in GRE, presence of multiple blooming artifacts within the mass, mainly at the peripheral aspect of the lesion. And then on DWI ADC, we can see presence of area of restricted diffusion, patchy area of restricted diffusion within the lesion. Hyperintense on DWI and hyperintense on ADC, in keeping with restricted diffusion. And then I go back to the okay, so I'm going to describe regarding the extension of the lesion to the surrounding structure. Okay, so we focus on the post-contrasted study. And then, okay, this lesion itself, anteriorly, we can see the neurovascular bundle is pushed by the lesion. However, the forward signal within the lesion is still preserved. Mainly, we can see at the T2 echo, the blood forward signal within the blood is still preserved. And then we also can see at the posterior lateral aspect of the lesion, it is the mass is compressing onto the gastrocnemius muscle, and then anterolaterally also the mass is seen pushing the adjacent and posterior tibialis muscle. And then we can see also a few abnormal signal intensity, which is in the adjacent medial head of the gastrocnemius muscle. We can see there is a patchy area of iso-intense signal on T1 weighted, hyper-intense on T2 weighted, on stir, not suppressed on stir, and then not enhancement in post-contrast study. This is in keeping with intramuscular edema. And then another abnormal signal intensity we can see is at the adjacent flexor, left flexor digitorum longus, which is, we can see the lesion is heterogeneously iso to hyperintense, and then heterogeneously hyperintense on T2 weighted, not suppressed on stir, and enhancement in post-contrast study, likely in keeping with infiltration to the left flexor digitorum longus. And then along the neurovascular bundle at the proximal tibia fibula, we can see few enhancing rounded lesion, which is enhancing in post-contrast study, likely in keeping with lymph nodes. Other than that, there is no extension into the adjacent skeletal. The normal signal intensity of the skeletal muscle, skeletal is still preserved. Okay, then this patient subsequently after MRI proceed with CT-TAP on 30th of June, I think. Okay, so from the CT actually, we find there is huge heterogeneously enhancing mass at the right side of abdomen, where the mass is seen arising from the right kidney, where we can see the mass causing the obliteration of the normal anatomical of the right kidney. And then the mass is heterogeneously enhancing with area of hypodensity within in keeping with necrotic center. There are also multiple foci of calcification seen within the mass. And then the mass causing surrounding mass effect onto the adjacent structure, which is the liver, right adrenal gland, as well as the surrounding vessel. And then other than right renal mass from the CT, we can see also multiple liver lesions seen, as well as multiple lung and pleural-based lesion nodule. So correlating with CT TAP findings, most likely this patient is the primary is from the right kidney, which is we thinking is RCC at the moment. So with multiple metastasis to lung as well as to the left cuff. So the left cuff intramuscular mass that I mentioned just now is basically metastatic lesion.
Can you share with us the bone density? If it is RCC, incidence of bone quite high.
Okay.
Mana right scapula tu? Kiri balik, right scapula. Tengok the whole body punya bone.
Any question from the floor?
So what's your final diagnosis? Have you had
Final diagnosis is
MRI?
with the MRI. So for the MRI itself, our final diagnosis is intramuscular soft tissue mass, likely metastasis, prof. Other differential diagnosis could be soft tissue sarcoma, such as synovial sarcoma.
Shurahbil here. Can you see again the lung lesion? There's a huge lung lesion there. And then based on this, which one is more likely? The lung as a primary or the kidney as a primary? Or is there any features to say multiple pathology in this case?
Looking at the city overall, there's a multiplicity in terms of the lung and pleural base actually masses, and to see that the whole renal is actually occupied by this mass. So that's why our diagnosis was more like this being the primary, which is causing metastasis to the adjacent liver. And there were also nodal mets. There were multiple enlarged abdominal nodes as well. So which indicates that there is some malignancy in the abdomen, and this is actually more common for a renal RCC to have a cannon wall metastasis. As for the skeletal part, it's rare, but there is also a tendency for RCC to metastasize to the skeletal muscles, rather than the skeletal muscle being the primary, causing extensive metastasis to the kidney, liver, and to the lung.
Okay. So you mentioned there's a bone lesion that's over the right scapular region. What about any pelvic bone?
Actually, the bone, we think this one is more of the contrast that was given probably on the right, doctor. These are all the prominent vessels which are seen opacified around the scapula. But when we
Okay.
look at the bone windows, yeah, just give me a moment. So by re-looking at the bone scapula, we don't see any suspicious lytic or sclerotic lesions.
Okay. So this case is actually referred to us because of there's a lesion of the calf, but it's painless. But the main symptom that patient came to the hospital because of the dry cough, and then there's no issue with the urinary symptom. There's no hematuria and so on. But the main issue is the lung. So medical was thinking whether the lung is the primary. And then once they found there's a lesion over the calf, they were thinking whether it could be sarcoma next to lung. But when we see again, there's a how we call it. Initially, they were thinking hepatomegaly because of palpable mass over the right upper quadrant. So then, based on the behavior of sarcoma, is rare for the sarcoma to go to the liver. But that is why our initial diagnosis is number one is maybe different pathology with the calf, or if it is same pathology, then it is metastasis. And then the behavior of metastasis to the soft tissue for the carcinoma is rare. And then we talk about RCC, metastasis to the soft tissue is even extremely rarer. So, but we did a biopsy over the calf as well as over the lungs. So we are waiting for the final biopsy report. But they were mentioned about the different pathology from these two biopsy. But we need confirmation from the pathology. They are still reviewing the slide.
Should I be here?
Yeah, Prof.
So the plan currently, with the information that we have, while waiting for histology and the tentative communication that you have from histology is two different pathology from the lung tissue and also the calf tissue. Is that correct?
Yes, Prof.
Okay, so tak berapa nak discuss kot lah. Kejap tu very academic lah in terms of
yes, Prof.
The approach is quite a number, is it not?
Yes.
Lung primary, is it a kidney primary, or is it two primaries and then CAF separate, so banyak sangat discussion. Kemudian lah when you update us
Later.
on this.
Yes, later we come again and then we'll discuss this case because it's quite interesting because the behavior is quite different. So if this turn out to be RCC and then the primary has to go, and then probably the lesion of the calf because if it is metastasis and then it's a systemic disease already, so maybe there's a role of we call it pazopanib for the systemic, and then we see the response for the soft tissue. That's just a rough idea on if it is it turn out to be RCC.
Just a few minutes more lah, Syarabil lah.
Yes, Prof.
Only with medical or conservative management, does RCC has I mean in terms of the whatever possible now, quite number, I mean lung, there's a role of I don't know, medical treatment of lung as well with biologic agent. RCC has also some role in terms of that, is it not?
Yeah, I think so because this is if you based on the systemic burden now is considered as metastatic disease. So the priority now is to go systemic, which is the option we have now is a TKI, tyrosine kinase inhibitor, and then it has a response towards RCC, and then there's a two approach for the RCC, whether to excise the primary or just to give the oral chemotherapy TKI. But if this turn out to be lung as a primary, and then still we have the role of biology agent, which is TKI as well. But I'm not sure which one is which the best for this patient. Right? Any more question? I suppose if we have no further question, shall we conclude our session today? Thank you for all the inputs.
Thank you.